Good afternoon. In today's session of Connections, we're going to be talking about the changing roles of pharmacists in the US and Israel. Joining me in today's session, I have two distinguished thought leaders. Dr. Adam Rose is a physician researcher who moved from the US to Israel 2 years ago. In the US, he was a physician researcher at the RAND Corporation and an associate professor at Boston University. He's now an associate professor at the Hebrew University School of Public Health. His areas of research have included how best to address suboptimal prescribing of medications such as opioids, anticoagulants, and testosterone, as well as research about optimal delivery of primary care services. In addition, he has studied the professional contributions of clinical pharmacy as a profession and its development over time. Several months ago, Dr. Rose published in our journal an article entitled 7 Key Parameters that Facilitate Clinical Pharmacy Practice, a comparison between Israel and the United States. Hi, Adam.
Hello.
We also have with us Dr. Eyal Schwartzberg, a qualified pharmacist with more than 20 years of comprehensive experience in academic, management, and professional activities. He has served as Israel's chief pharmacist and is head of the Ministry of Health's Pharmaceutical and Enforcement divisions. He's currently an associate professor at Ben-Gurion University, where he leads the master's program in community clinical pharmacy and regulatory management. Dr. Schwartzberg is also the founder and CEO of Applewiser, a startup that uses digital technology to help consumers make more informed choices about the purchase and consumption of OTC medications. Hi, Eyal. Thanks for joining us.
Thanks for inviting me.
Good. Good to have you both with us. Adam, can you please get us started by explaining the meaning of the term clinical pharmacy and how is it different from basic pharmacy?
Okay. All pharmacists are qualified to dispense medication, to compound medication, and to give patients advice about how best to use their medication, especially if the patient doesn't understand. These are classic pharmacy functions, and all pharmacists can do them. Clinical pharmacy takes it a step farther and adds new functions to that, including the ability to change the dose of medication or to prescribe other medications like it, with the goal of achieving a pre-specified clinical goal that's been specified by usually a physician, such as bring this patient's hemoglobin A1C below 8. And then the clinical pharmacist will do all that is necessary to accomplish that. And that includes prescribing, changing doses, ordering and responding to tests, lab tests and the like, to see how the medicine is working and whether there are important side effects, and also speaking to the patient and taking a relevant history about their use of this medication, how they're controlling this condition, and what can be done better. So this is important because it enables people like physicians to delegate big functions to these clinical pharmacists that would otherwise be very time consuming, and that actually the doctor may not even always do as well as the clinical pharmacist.
I'm going to hold you there. Thank you. Eyal, could you please share with us your views on how clinical pharmacy benefits patients and health systems beyond what's provided by basic pharmacy?
So from my own knowledge and my practice many years ago as a clinical pharmacist, I was working with physicians, especially surgeons, and those guys were working really hard to perform excellent surgery. However, at some fields of pharmacotherapy, they were less orientated. And when the clinical pharmacy joined them, we were able to change the way they're prescribing to a more rational and safe use. For example, with the use of prophylaxis antibiotics and when to stop them and when to convert to IV to per-os. So that was one thing. So it's really working with physician, and I look at the clinical pharmacist a bit like a medical representative. He should do he should work with the doctors in order to change the way they are prescribing, especially when the prescribing is not, when the actual prescribing is sometimes not very accurate, or it didn't take into consideration all patient factors which are changing, or when you have many disease states and other comorbidities with a lot of polypharmacy. This is where a pharmacist, a clinical pharmacist who's a specialist, can help the doctor. On the other hand, clinical pharmacists should work with the patients, so they can educate them on how to take their medication better. And since they have a higher degree of qualification, not just academic, but also practical one, they can help them to adhere to their therapy, especially now when we deal with people with chronic diseases. So they are like coaches for taking taking the medicines for the right time, with the right dose, for the right patient.
Okay, yeah, that's very helpful. Adam, in your recent article in the Israel Journal of Health Policy Research, you identified 7 dimensions in which you felt that the development of clinical pharmacy is more advanced in the US than in Israel. Could you maybe pick out two of those dimensions, tell us about them?
Right. So we had talked about that, and I had said I was going to do 3, and you said it was okay because I had trouble choosing 2.
Okay, go for it.
So
But brief.
The 3 that I picked were, so there were 7 factors that were necessary for clinical pharmacy to sort of fulfill its function fully, and for clinical pharmacists to add and contribute as much as they can. So the 3 of those 7 that I thought were important to discuss were the advanced degree, such as a master's or a PharmD, the idea of postgraduate residency, and the idea of scope of practice. So with regard to the advanced degree, I went over in my article, and I was also quoting an excellent report by the American College of Clinical Pharmacy about how the PharmD degree started out being a very small minority of pharmacists who got it in the 1950s. And by, I think, the early 00s became the only degree you can get and be a pharmacist in the United States. So any pharmacist who completed their training in the last 20 years have gotten this PharmD degree, which is a kind of doctoral degree in pharmacy. And for the most part, that degree already prepares you well to do a lot of the functions that are expected of a clinical pharmacist. In Israel, there are some people getting these advanced degrees, but it's a minority. And then the other important element is that more and more, to be a clinical pharmacist in the United States, you have to do at least 1 year, and depending on what you plan to do, sometimes 2 years of postgraduate training after your degree. And there are thousands of spots every year in programs that help these young pharmacists hone their skills of patient interviewing, titrating medications, ordering relevant lab tests and reacting to them, so that they become really very good at handling conditions. And before I mentioned diabetes as an example, but there's dozens of conditions that they can help handle, including chronic lung disease and osteoporosis, and the list goes on, chemotherapy. And a second year of residency training is often necessary to do some of these highly specialized things. For example, to work on oncology drugs, I think you would want a second year of residency specifically in oncology. And then the third thing I said was the scope of practice, that it goes state by state in the United States, but there have been a lot of advances, although uneven, in the last 20 years in pharmacists being able to have a lot of semi-independent roles. Semi-independent because they're still working with a physician, but they have a lot of autonomy, at least in some places, in terms of deciding when to change the dose, which medications to prescribe, and the like, and also getting paid for doing that work, which is important over there, not as relevant over here. And these are three things that I think would probably, if they came along more, would help the Israeli clinical pharmacists to be able to contribute more fully and to do the things that I think many of them are already well capable of doing.
Okay, Adam, that's very helpful. I now turn to Ayal. Do you share Adam's view that Israel is behind the US on these three dimensions? And if so, please share with us your thoughts on why Israel's behind and what it can do to catch up.
So I think that to some degree we are behind, but we've got some. I would say that in order to compare apples to apples, they need to be both apples and not apples to pears. Okay, and as an ex-regulator who was involved in the Israeli legislation for clinical pharmacy and for pharmacy in general, I think that as far as it goes for the training, we might be following a little bit more of the UK model, whereby people are doing their masters or PharmD's degrees and they are going directly to work. So the residency is important, and no doubt if this could have been integrated, that might have helped, but I don't think it should be an obstacle to start practicing, and some hands-on experience could be purchased throughout training with the knowledge and the actual training in the clinical fields while pursuing the masters or the PharmD. That's one thing. As for the scope, Israel healthcare system is very much different to the US one. And I think that if we look at conditions that are contributing towards the I would say the growth of clinical pharmacy in the States, we should look at a few things which are not that embedded in our culture yet. One is to do with the automation and robotics. There is a lot of automation in robotics going in the States, whether in community pharmacy and whether in hospitals. This actually saves on pharmacists' time and allow them to practice more in the clinical dimension than doing the logistics. The other thing is that we are a fairly young nation and a fairly young health system. And you should consider also the fact that until 2000, there was only one school of pharmacy, and only at around 2008, the first class of PharmD, and now in Ben Gurion University in 2019, we've initiated the master class. So it's really difficult to compare 40 years of, or 50 years even from the 60s, the evolution of clinical pharmacy in the States. The other thing that is supporting the environment of the development of clinical pharmacy in the States, I think it's the ability to have technicians in the systems. In Israel, the number, I looked at the number of pharmacists, practicing pharmacists in Israel, not just clinical pharmacists, where we have about 250 and only 150 are practicing. We have similar amount of pharmacists per 100,000 people, citizens. But in the States, there is 1.5 technician per pharmacist, where in Israel there are none. Therefore, when you come and try to use pharmacists or even clinical pharmacists, you need to do the bread and butter first. It's still the logistic. It has to change definitely. And finally, when you look at the States, they have the MTM system, which was initiated by this, I think it's the CSM, Medicare and Medicaid, the centers.
CMMS.
CMM, yeah. Yeah, sorry for that.
And just also MTM is medication therapy management.
Yeah.
Yeah, go on.
MTM, medication therapy management. And as part of that, pharmacists are being paid. They are still not acknowledged as providers. They need to subcontract with bodies that actually are doing that. But it will happen at some point in the States. And I think that also here in Israel, first, I think that clinical pharmacy should establish. In my PhD, I researched why clinical pharmacy was not embedded and implemented in Israel at the year 2000s and before. Okay, I've done my PhD from 2005. At that point, we didn't have a lot of clinical pharmacists, but now we have 150 practicing clinical pharmacists. The HMOs are taking them; they are understanding, and I think if we want to continue ahead, it's not just the scope, it's allowing pharmacists more time. And in order to do so, we need to free their time by giving them additional help, like we have physician assistants, we should have pharmacy assistants or technicians that will allow them to practice more clinically. And then we should also negotiate it. When I say when we, because I'm part of the Pharmaceutical Society of Israel and I'm still involved within the academy and also within a little bit with the Ministry of Health, allowing pharmacists and HMOs to work together towards a defined outcome. It's very important to decide where those pharmacists are going to practice, not just to take what was done in the States or in the UK, but to look at our system and say, okay, we have a problem with adherence, let's face that. We have a problem with reconciliation with MedRec, let's do that. But we need first to scan those and not just to jump into the water and say, all right, if they've done it in the States, it's going to work here in Israel. It doesn't work this way. There is a phrase which is called NIH, which is not the National Institute of Health. It's not invented here. And I've heard it many, many times. People want to see evidence from Israel, not just comparisons of system. There is always a difference. The question is why the difference is there and how we can bridge the gap in order to move forward according to our culture. Not to say clinical pharmacists are not important, they are very, very important, but we don't have enough resources maybe, such as in the States, and we need to use those more carefully and more, I would say, focused on the needs of the health system.
Okay, that was very helpful. Adam, any reactions to those interesting and somewhat challenging comments of Eyal?
They are interesting. Absolutely, I think that that whatever roles you build for clinical pharmacists have to take account of how the system really is here, and shouldn't just try to emulate what's going on elsewhere, because it may, as you said, it may not fit. And it's interesting to hear you say that it makes sense for the clinical pharmacist to gain, as it were, on-the-job experience, and maybe something like residency programs would start later, because that basically echoes exactly what happened in the United States. The first and probably the second generation of clinical pharmacists, they didn't have any residency programs. They just figured out how to do these things. And then only, thereafter, the third generation, as it were, of clinical pharmacists really had access to these residency programs. I will say that in my research, I've observed that, the older pharmacists who sort of did the gaining job experience on the fly, like in the trenches, and when you compare them to their younger colleagues who did a PharmD and also a residency program, the younger colleagues just look sharper sometimes when talking to patients. And you can always have some people that are naturally talented at taking a patient history, but it's really hard to have a substitute for having been formally taught, how do you interview a patient? How do you carry on a clinical conversation with a patient? And so unavoidably, Israel's first teachers of those skills will be people that weren't formally taught those skills, because nobody was around to teach them these skills. But I will say that it's very difficult to the quality of the performance, because I watched a lot of clinical pharmacists practicing in anticoagulation clinics usually. And you can't compare, it's a much more even performance by lots and lots of people in the generation where people did residency. Whereas in the earlier generations, some people kind of are talented and arrived at it on their own, and some people just don't end up looking that good when they try to, do clinical practice with patients. So I think the important function of the residency is creating a much more even quality of practice, that everyone is brought up to the same level.
Hey, Al, I see you
So-
wanted to say something.
Yeah, I agree with Adam. It's just matter when to do so, because at the moment, I think we are at the stage that we need to show the impact. If we would send them for additional 2 years, there are two problems with that. First, we would delay their implementation of clinical pharmacies because they will be in university and they will not be available, and that will create gaps within the service. That's one thing. The other thing is that when it comes to clinical pharmacy, and even if they would be working while they are practicing, they can still gain a lot of information and publish it in order for their predecessors, people who come and will join them later on, will have experience to build on them. And the other thing I wanted to say is that here in Israel, it's not that easy. I don't know what was the situation in the States, because the board of pharmacies are for each state. But here in Israel, once you are a pharmacist, you are a pharmacist. There is not such thing, a clinical pharmacist by, let's say, title. It's more of a job description, okay? You still need qualification these days, because there is the circular from the director general from the Ministry of Health saying what clinical pharmacist qualification should be. But in order to make people go back to universities, in order to get their specialization, you need to change the legislation. That can take a long time, and this may delay the implementation of clinical pharmacy. And we tried at some point to bring exams, continuing education exams, in order for pharmacists to renew their certificate. And there was a lot of
Pushback.
yeah, pushback. The least I can say, why are we the first to do that? Why other professions are not to do that? And you will cause us to disappear and blah, blah, blah. And I said, okay, if that's the case, let's continue. You would take your exam when you finish if you're coming from overseas, or you would be entitled after your pre-registration half year to get the license. And then you would continue to other qualification, whether it's a master's or a PharmD. But possibly with the development of technology, and also pharmacy is an evolving job at the end of the it's an evolving trade. It's not the same. We used to be focused on the product, now we are focused more on the patient. And in the next few years, with the addition of clinical pharmacists, and also the fact that people don't want just to do logistics work or just to do dispensing, and the robotics that will join us, things will change. Things will change anyway.
Gentlemen, our time is almost up, but before I wrap up, I want to give each of you a chance to say one or two sentences, parting thoughts. Adam.
Well, it's been great speaking with you, Eyal. You have a lot to say about this topic, and it's very thoughtful about it. I agree with what Eyal is expressing, that I think, and honestly, this is not this is not conflicting with what happened in the United States. Is that, there's this expression that you have to build the plane while you're taking off, or while you're flying it, and as Eyal mentioned, that pharmacy really is a changing field. I think a lot of medical professions are changing because of information technology and because of even changing societal attitudes about power differentials and who's in charge, right? Patients are much more empowered than they used to be. But pharmacy is changing especially fast, probably faster than a lot of the other health professions. And Eyal is right, it's going to change, without anyone even pushing for it. I think some of the things we discussed in the article, such as actually having a specific designated certificate in clinical pharmacy, or having actual jobs that are just for clinical pharmacists, which I know is starting to happen, is an important development, will be an important development, and to some extent already is, because it creates, as it were, a bar that people have to clear to do a certain sort of function.
Okay, thank you, Adam.
Yeah.
Eyal, just a couple parting thought.
Yeah, well, if we are into flying, so we are still growing our
Wings.
and feathers. So we are flying not that high yet, and we are trying not to burn ourselves from the sun, so we wouldn't fall into the water. But otherwise, I think that it will change. It will keep on changing. As Adam said, the profession is changing all the time, and we should embrace technology because that will bring something which we didn't have until now. We didn't have enough time. And today there is a shortage of pharmacists. So I think that we should look at two things. First of all, how we can decide on outcomes and measures that will benefit the HMOs here in Israel and work with them together in order to put those in job description, so we would have a clinical scope for clinical pharmacists as well as to maybe other pharmacists for the transition period. And then once we will be able to have this, we need to publish those. We need to do more than just, not to say that showing how other systems work is not important, but we need to bring our own data to support what was already shown in other places in different environments. Once we'll do that, and it will take few years, I think it would be much easier to implement it here in Israel, and then maybe go on solo flights and not just as co-pilots. But we are getting there. We are working on it.
Okay, Adam and Eyal, I really want to thank you. This has been a great session. I think we all learned something. I think our viewers and listeners, once we post this on the website, will also enjoy it very much. I think we've sort of illustrated what we're trying to do with this Connections program, that things that you can have in a real conversation, a live conversation, you can take things further than you can in an article, even in a written exchange. There's something about the dynamic. And my hope and expectation is that the two of you will be in touch offline. I think between the two of you, you could do good things for pharmacy in Israel, for patients in Israel, and perhaps beyond. So thank you very much for joining us.
Definitely. I'll take the opportunity to welcome Adam first to Israel, and then, like, after that, come and be a visiting lecturer in our School of Pharmacy. I'm sure you will be able to contribute a lot to our students for the master's and for the bachelor programs. They can always learn, and good things will come out of it, I'm sure.
It would be my pleasure. It would be my pleasure. Thank you, Eyal. It's a pleasure to meet you.
Thank you.